We're so delighted to have Dr. Michael Tregakis from the VA here with us today.
Just the slideshow.
All right, Dr. Tregakis is a licensed clinical psychologist who has worked with our nation's veterans for over 10 years. He currently serves as a suicide prevention clinical director in an outpatient mental health clinic at the Salt Lake City VA Medical Center. Prior to this role, he served as the coordinator of the dialectical behavior therapy team at the VA, having been intensely trained in this modality. He has a passion for teaching and mentorship and has won numerous awards for his contributions to learning. Dr. Tregakis has enjoyed educating students and staff in numerous evidence-based psychotherapies, including social skills training for severe mental illness, interpersonal theory for depression, as well as DBT. Dr. Tregakis is also proud to be an adjunct assistant professor in the Department of Psychiatry at his alma mater, University of Utah. Go Utes!
Yeah! I had to do that. Thank you so much. Good to be here today. Go Utes. Sorry, I had to say that. Just a quick overview. Trying to prepare for a suicide prevention, suicide ethics presentation that's going to last an hour and maybe a little bit under. Wow, daunting. There's a lot here. There's a lot to talk about. So my hope today is to just kind of share some key issues with everybody about the ethics of suicide and suicide prevention, maybe spark some new ways of thinking about this topic, and then just help people gain a little bit of perspective. It has been great with the panel discussion and Taryn's presentation. All of this is going to dovetail really nicely together. So our objectives want to just provide a little primer on Utah state and national ethics guidelines for suicide prevention, and gain an appreciation for a big emphasis today is to gain an appreciation for the new evidence base with regard to suicide. And then if we have time, we'll make time. We want to discuss a few ethical dilemmas with regard to suicide prevention. This seems to be doing a little bit of feedback. Some quick thank yous. I wanted to thank the BYU School of Social Work for allowing me to come. It's a real honor. And wanted to thank a few folks at the department, Utah State Department of Human Services, Kim Myers and Andrea Hood. It's been really wonderful to be able to collaborate from VA to Utah State and beyond. Also want to give a shout out to the suicide prevention team at the Salt Lake VA. I'm the newest member of our team, and I'm just really grateful to be part of it. And then certainly the Community Affairs Associate Chief, Rebecca May. All right, so starting a little bit with some definitions. Suicide, any voluntary action to take one's life. So this is going to be focusing not on the self-harm behaviors, but more of any behavior that's aimed at taking one's life, maybe an attempt. And as Taryn was saying and the panel was saying, this is always going to be about eliminating suffering. This is not something that comes up willy-nilly. And as far as ethics go, so when we think about ethics, this is going to be the principles that guide our behavior, and it ties into morality. So morality has to do with principles of right and wrong, and then also our values. So maybe personally held values that we may hold as a social worker or a psychologist. So this presentation is going to be kind of drilling down on these topics. In the service of time, and because of Taryn's good work earlier this morning, I'm not going to emphasize the data, but I do want to underline suicide is a major issue. Okay, 10th leading cause of death in this country. As Taryn was saying, over 47,000 folks die by suicide in a year. Those are 2017 data. I bet that's an underestimate, and that's from 2015, so we've got inflation, but $69 billion spent per year on dealing with suicide. I'm going to, just again, in the service of time, Taryn did a really nice job here. Are folks aware that we live in the suicide belt? Has anybody heard that term before? Okay, so Rocky Mountain region and maybe the rural Alaska, it's a huge issue. We have the highest rates of suicide in the country. And we can maybe talk about it as this presentation moves forward. What's the roots to that? Okay. Certainly as a VA provider, suicide is a major veteran issue as well. Maybe folks have heard the statistic of 22 a day. Has anyone heard that statistic? There is a data that shows that 22 veterans attempt suicide per day, complete suicide per day. One of the main factors, we're drilling down to this, of course, are multiple deployments, the stress of reintegration, things like that. Pretty worrisome, though, is that this is an issue that crosses the lifespan. When I was looking at World Health Organization, the data across the world here, and then as we drill down to the United States, suicide is the second leading cause of death for people 10 to 14 years old. Okay? Teenagers, also second leading cause of death. So if we think of morality, if we think of what's right and wrong, then dealing with suicide is definitely something that we want to do. It is important to note that this is an international problem as well. So we've kind of alluded to it earlier in the different presentations. Suicide's a pretty touchy subject. There's a lot of avoidance. Clinicians, lay people, there might be this tendency to just try to avoid the whole thing entirely. And so there may even be this sentiment like, is this really my responsibility? Right? Yeah, that Taryn lady, she sounds great, but yeah, I'm gonna just let the crisis worker take care of that. Or how about let's get the person safe, let's get them to the hospital, and then when you get out of the hospital, then we'll get back to work. So I'm speaking as a clinician here, speaking as a therapist. There can be a lot of blame to issues around suicide. So, well, she just needs to take her meds, or he needs to come to his therapy appointments and not just keep going to the ER. If this person, if she would stop getting in these relationships, if he would stop getting in those relationships, get over the past, okay? So what do you call that when you keep doing the same thing, expecting different results, and in this case, keep doing the same thing, but expecting suicide rates to go down? What do we call that? It's actually called unethical. Tricked you. Okay. So here we are in social work, right? School of Social Work. The Code of Ethics tells us that we are responsible to become and maintain, be proficient at our fields, but really to keep current and critically examine emergent knowledge with regard to the issues that we're facing. So this tendency to avoid, this tendency to let someone else's lane, let's let the crisis worker deal with it, it's not working. So what we really want to start to do is to follow current evidence-based guidelines with regard to suicide prevention. So if you're going to be up to speed there is the 2012 National Strategy for Suicide Prevention. And this was developed by the Office of the Surgeon General, also in collaboration with the National Action Alliance for Suicide Prevention. And it's being disseminated by SAMHSA, the largest mental health and substance abuse arm of the federal government. One of the nice things here is this particular program goes beyond our tendency to avoid. It goes beyond the focus on the individual, which is, it's been a theme today. How do we help the individual? What we're going to see here is that suicide is a real systemic problem, and we need to address systems issues, culture change, and not just the individual. So this program offers collaboration and actually requires and mandates collaboration between federal agencies, state health departments, community clinics, and so forth. So let's recap a little bit what we have been doing, and then I'll contrast it with the new plan. Okay? Suicide has often been viewed as a management problem. Again, a lot of hot potato kind of mentality with regard to suicide. Clinicians tend to focus on symptoms. Let's get them contained. Let's get you to the hospital. Let's get you on antidepressants. And then let's get you back and we can get back to work. Okay? There's been a lot of avoidance of talking about suicide. And I know in my past practice, excuse me, am I still on? Okay. In my past practice, there has been this tendency to think like, no news is good news. Okay, they haven't talked about suicide. That's not something that we need to worry about. And we tend to work in silos. Okay? We tend to, again, like that's the inpatient setting. When you get back, we'll work on other stuff. We've also got maybe an Old West mentality here, let's buck up, buttercup. Okay? Maybe this person just needs to toughen up a little bit. That's why they want to commit suicide. Promise me you're not going to do anything crazy. Okay? We tend to sort of try to get agreements with our patients that, one, are a little bit sort of judgmental. We also try to rely on our gut when, as the panel discussion was saying, maybe our gut isn't always accurate. Okay? We can also put a lot of responsibility back on the individual where, as it's been clear today, the individual who's thinking of suicide is really in a vulnerable, emotionally complicated and compromised spot. So what is the new evidence base? So suicide can be prevented and predicted. We want to talk about suicide explicitly before, during, and after an event. And as the panel was really highlighting, say the words, talk about suicide. Get for students in the room, get practice with this. It's going to take a little bit of practice. And three main areas that we want to change. We want to change the culture with regard to help seeking. As Taryn was saying earlier, we want to normalize the idea that suicide can be something that happens. We want to adapt and augment systems of care so that the VA approach that's trying to adopt this is there's no wrong door. There are lots and lots of entry points for suicide prevention. And then certainly, we want to address the big picture issues. And this is probably one of the newest areas that we know that research shows we've got to focus on, which is the idea that suicide is a public health issue. Certainly there are individual issues, but there are some macro level issues as well. Okay? So as a result of this 2012 national strategy, we have some really great resources that I wanted to make sure everybody knows and uses, okay? So there is a national website called the Suicide Prevention Resource Center that will really walk you through all the different approaches to suicide prevention and provides a lot of resources here. Okay. One of the big resources that Taryn was talking about we use at the VA, see if I can get my little pointer to work, is the crisis line, 1-800-273-8255. That number again, 1-800-273-8255. This was developed as a result of that national strategy, and what's really fantastic is that we can all use this. We can all make use of it. And again, it goes through different contributors, I love this diagram, pieces of the puzzle. What are the different factors that lead to suicide, and how can we address them? The other big piece that new research shows is that suicide is not a moment in time. Okay? Suicide is something that can involve and should involve a lot of preparation before anyone is in crisis. And again, it's another theme that we're talking about here today. So a lot of prevention. The evidence base also shows that we really need to start to be more targeted when we are intervening in moments of crisis, as well as with folks that are chronically suicidal. And then there's also an idea of postvention. So one of the biggest challenges here is that suicide and attempts or suicides that have gone all the way, they are very emotionally stressful for providers, families. Even if the person attempted, it's still very, very stressful. So all of this needs to be addressed as we're trying to follow the evidence base with suicide prevention. So even though we may think that someone who's about to jump off a bridge is just in an acute moment of crisis and we need to deal with that acute moment, that's actually not the truth. The other piece of the puzzle, it's not just one single individual here. This person is in a context of a neighborhood, a community, a state, a nation, and so forth, that has maybe some macro level issues that we need to address. Okay? So let's talk about prevention. And again, if we're going to follow our ethics code, psychology is the very same here. We need to keep current with the evidence base. We need to really evaluate the different strategies we're using, and we need to implement them. Okay? So first, talk openly about suicide. And again, this ties into some of the things we've been talking about today. Ask the question. The more explicit you can be, the better in terms of somebody's safety level. If you are someone who's going to be talking about suicide to someone else, they're going to know that you're open to that. They know that you're not going to judge. Another big piece here is we want to capitalize on peer supports and lived experience. In the service of normalizing the conversation of suicide, the idea that if we share our own stories of pain, distress, attempts, addiction, what have you, that is going to be a real big open door. And what we know now is that we really need to continue to do this. And again, for students in the room, this is going to be something that maybe takes some practice. This is going to be something that maybe you want to work on with some trusted family members or colleagues, and then expand into your practice. Another big piece with prevention is we want to use data to start to predict and respond to individuals who may become suicidal or who are on that verge. So for example, the VA has a lot of data that it can pull from. It does a lot of huge federal system, has a lot of information that they collect on all the veterans. We have started a program called ReachVet, which aggregates information about folks that may predict suicide in the future. So things like history of mental health issues, something like addictions issues, even certain demographics like is this person single, and so forth. It takes a huge computer, compiles all this data, and then it provides we have a ReachVet coordinator, this program coordinator, who then reaches out to people way ahead of any suicidal event. And it provides the opportunity to augment treatment, to provide that additional support that we're talking about. So for some of the different systems, maybe larger systems that you might be working for, this might be a capacity for you as well, to use some of that data that has already been collected to be proactive with regard to suicidality. The other piece of the puzzle with prevention is that we want to use evidence-based screening procedures. And the bottom line is we want to use evidence-based procedures across the board, but for suicide, maybe even a little bit more important. So some of the screening instruments that you might think about are screening instruments that can really distinguish between folks who might be thinking a little bit about suicide versus folks who we really need to respond right away. Some of the items, the instruments we're using at the VA, the PHQ has an item at the end that asks explicitly about suicide or wanting to take your life. We are now starting to ask that in every clinic of the hospital. So primary care, medical, surgical, sleep clinic, it doesn't really matter. Any place, we are going to start to ask that question. And that might be something, again, for folks in your practices, in your community settings to do. Another instrument that's got a lot of great validation is the Columbia Screening Instrument. And the bottom line with that particular instrument, it is making sure that you're checking the boxes, you're being very thorough about someone's suicidal intent, suicidal plan, means, and access. Those key questions. Once someone is deemed to be at risk for suicidal behavior, or they're sort of in the throes of suicidality, another big piece of using the evidence base is to evaluate and track the person over time, and to calibrate the plan that you use as a result. So one of the research hubs at the Salt Lake or at the VA in Salt Lake, has drilled down and discovered what are the specific interventions that we need to do depending on the different levels of risk. Okay, and there's a link here in the presentation, which I know will be available to you after. If somebody has low risk, okay, maybe we want to provide additional care and supports. But if somebody is way up to high risk here, we're going to maybe need to do something a little bit more assertive. We may need to be maybe considering hospitalization and so forth. Okay? These screening instruments can help us be quite precise and calibrated in terms of how we intervene. And what's nice is that if you're going to be using these evidence-based measures, you can point to them as a solid, defensible reason why you made the choices you did. So it's kind of got this sort of individual care element to it, as well as sort of a protective piece to agencies using it. Okay. Intervention. Certainly, and again, just to really underscore what Taryn was saying here, we want to create suicide safety plans, and the key here is to do this before there's even a little wiggle of an idea. Early and often with suicide safety plans. I do want to put another plug in for Craig Bryan at the University of Utah has developed a nice augmented suicide safety plan called a crisis response plan that involves reasons for living. Okay, a lot of safety plans will have a person look through triggers, things that distress them, have them look through common coping strategies that they use, common supports that they have. But reasons for living is going to be kind of that sort of that crowbar in the gears here that maybe gets someone to remember why I'm doing all this in the first place. A person with suicidal thinking is in a very distressed place, and to have that reminder, have that picture, and what have you. Okay? So suicide safety plans are critical. Have as many people participate in suicide awareness training as possible. So thank you very much, everybody, for being here. Has anybody ever heard of Hope Squad? I know that this is where it was created, so I was just trying to joke with you, everybody. Sorry. Hope Squad is a wonderful model, QPR model. A lot of folks here we're talking about their training in question, persuade, refer, different strategies to help everyone become more aware. The more that everybody's aware and can pick up on those signs that we're talking about here today, the quicker and earlier we can intervene. Some links here for the different programs that you can find. At VA, we use the SAVE training. And just, again, I guess I'm bragging a little bit about VA because it does feel like we might be on the vanguard. Every staff member gets trained in SAVE. So this may be something to think about here for your different settings. The other piece of the puzzle is to rely on evidence-based therapies. So I've got a lot of familiarity. I've got a lot of familiarity with dialectical behavior therapy. So that was a therapy. I continue to do DBT, but I was ahead of our team for years. Really effective in terms of reducing suicidal thoughts, self-harm, and other impulsive behaviors. There's also CBT for suicide prevention. Again, the great work done by Craig Bryan at the University of Utah. Evidence base shows that these work. Our ethics codes tell us we need to follow the evidence base. Okay? The Old West strategy of I've worked with these folks a lot. They're not going to do anything. They haven't done anything yet. It may not be working. Postvention. Postvention I find to be the toughest, and toughest I mean emotionally. The more that we can be prepared for what is required here for postvention, and the more that we're aware that that's actually part of the suicidality process, the better that we're going to serve our communities and our clients. So postvention has to do with the response to the aftermath of a suicide, whether it's a terminal suicide or it is an attempt. So there's a lot of facilitated healing here. Family members are going to be struggling. clinicians are going to be struggling as well. And we do know that folks who have experienced a suicide, whether it's a family member or a client, unfortunately, they're a little bit more at risk for suicide as well. So postvention involves assertive care, a lot of response, a lot of resources, and again, this idea of no wrong door. It's part of what we need to do. Just to share a little bit, in the work that we do on the suicide prevention team, again, I find this to be the toughest. This is the part where you really, there are lots of parts of suicide prevention where you're no longer ticking any boxes, but postvention is really a place where you've got to just slow down, listen, be part of that. One of the challenges here, I think, as a society and maybe as clinicians or across the board, is a tendency to just want to skirt things along. Let's move it along. We also have, as I was saying earlier, maybe an idea that's not my lane. You can work that out with your colleagues. Let's get back to work over here in the clinic. That's going to undermine a collective well-being in terms of suicide and suicide prevention. Another big piece here is that suicide is linked to context, and that's, again, a big part of the 2012 plan. Okay, unemployment office is closed until we fix healthcare and climate change. Okay, so certainly we want to pay attention to symptoms. Certainly we want to boost protective factors. We want to limit risk factors. We want to be assertive. We want to create plans. But there's a huge context to all this stuff. We know that folks who are impoverished are at more risk for suicidality. We know that folks that are unemployed, folks that have been traumatized, abused. So how do we necessarily work with that in our offices? But again, if we don't pay attention to these public health issues, we're going to be our rates of suicide prevention are going to probably stay pretty consistent. Poverty, inequality. Anything anyone would add here? Any other big public health issue that you know is linked to suicide? Shout it out. What's that? Yes. Anything else? Loneliness. Social isolation, huge one. Absolutely. Okay? So these have to be addressed as well. I want to highlight one particular public health issue, which is pretty touchy across the country and maybe in Western states as well, which is guns. As Taryn was saying, guns are the most lethal means to suicide. And we just had some recent data where use of guns is just over half of all suicides, use of guns. 85% of attempts with firearms are fatal. On the other hand, folks that attempt in other ways, like pills or razors, what they have is it buys them time in a way that guns don't. So let's take a moment, and no chiming out if you don't like, but there's an ethical question here, isn't there? Okay, we've got the right to bear arms, something that maybe as a culture and as a country we hold dear, but is that also the right to die by suicide? Okay. What's really important here is we want to start to move toward gun safety, not gun control. I guess that will be a really important take-home message with guns here. Folks, especially at the VA, you can imagine, folks are very proud of their gun ownership. That's something that they're not willing to. They can get kind of Charlton Heston kind of thing from I hold that hand. Does anybody remember that? So saying I'm going to, guns cause suicide, we're going to take away your guns, it's not going to work. Okay. So some of the things to think about here. Using gun locks, using gun safes, separating the ammunition from the gun and somehow creating some space there, giving guns to a trusted individual during times of crisis, All of these things are going to be maybe palatable ways of preventing suicide with somebody who's pretty set on having guns. So when we think of the public health issues which need to be addressed, let's talk a little bit about what we do. Certainly, we can work on changing legislation about things like guns, or there was a lot of legislation that developed the 1-800-273-TALK line. There are also public health strategies that we can use to drill down to figure out how do we address this issue of unemployment and how it's related to suicidality? How do we address this issue of homelessness? Okay? So it's a cyclical path. This is a mini lesson in public health problem solving. First, you've got to do some surveillance and get some baseline data for the problem. Maybe get base rates, have a sense of how prevalent this issue is, where is it happening, and then we'll move through and start to identify possible causes to the factor, to the link between, let's say, homelessness and suicidality. Start to generate some risk factors, protective factors, and then develop and test interventions. Okay? So for example, we were talking today about the suicide in December at BYU. The clinic here can talk about, they really expanded their availability. The speaker was saying about 200 crisis appointments within a very brief amount of time. That might be an intervention that we want to sort of be to look at and say maybe this is a real successful element, a real successful approach that maybe we want to use again. Implement those interventions, but really importantly with public health issues, evaluate them, collect data. So the key here is to not feel unempowered. This is a reality here. We have public health, macro level issues that are leading to suicide, and now it's time to do something about it. Step by step, we can work together to do this. One of the grateful things I have about being in my role now is that we are going to team up with, again, Utah State. We're going to be teaming up with community providers, universities, churches. One of the big pieces is to expand outreach. VA in particular wants to go really far past the medical center doors and reach out into the community, start training, providing awareness training, outreach, supports, and so forth. Okay? And this is all related to, we have this huge problem. So let me speak to one of the problems that our outreach addresses. We have discovered over time that 6 out of 10 suicides for veterans are folks that were not getting care at the VA. So using this public health approach, we were realizing that we were waiting for folks to come to our doors, and we were ready. We had our bells and whistles and safety plans and so forth, but folks weren't coming in for lots and lots of reasons. Okay, one of the reasons is stigma, which we're going to be working on. One of the reasons is just access. Maybe folks are on one end of the continuum homeless and they can't get themselves there. And other folks, maybe they've got their own private insurance. No matter what, public health approach told us we need to go to them. We need to go out into the communities, start having the conversations about suicide and so forth. This is an approach that we can all adopt. Okay. Now, it seems very clear as I'm talking, okay, this is what you need to do. We need to be, take a public affairs approach. We need to use evidence-based treatments and so forth. Makes it seem pretty cut and dry, but the reality of suicide is it's not cut and dry. And when we think about the ethics of it, what I'd love to do is just to start to get people to kind of think about some of the ethical dilemmas that we maybe have with regard to suicide prevention. And I want to call in the role of values. So with morality, we've got right and wrong. With values, these are the guiding principles, okay? And for folks in social work, folks in psychology, folks in counseling, the beginning of our our ethics codes, there are some principles that are meant to guide us. So for example, in social work, the principles are service, social justice, dignity and worth of the person, importance of human relationships, well, we're talking about that a lot today, integrity, competence. Okay? Different fields have different elements, autonomy. Okay? Maybe if you come from a religious community, there are certain religious tenets that guide you, unconditional love, forgiveness. Okay? America. I guess I'll take the A off that beginning. America. Okay? Life, liberty, and the pursuit of happiness. Pretty straightforward. This is what we stand for. Okay? With suicide, there can be a real conflict, however. Okay? One of the biggies here, when I think of what we stand for as Americans, our Constitution, we've got liberty and autonomy, and we've got pursuit of happiness. With suicide, those don't necessarily go together. Same thing with life and the pursuit of happiness. If somebody is unbearably sad and dejected, they are going to want to perhaps take their own life as a mechanism, as a strategy to deal with that. So we value that. We value a person's maybe their liberty to make that decision. And yet we're also valuing life. Those don't necessarily go together. That's going to be something that as clinicians in training, we've got to kind of grapple with that as we make online decisions about what to do for folks. Let's give an example here, some ethical dilemmas. So a biggie with suicide is the duty to warn and protect. The idea that when somebody is suicidal, much like when someone's homicidal, we don't get to keep that, especially in imminent danger, we don't get to keep that confidential. We must act. And in fact, I'll show that we're mandated to do so. What about, are we responsible for non-clients, maybe family members, or just folks that maybe we meet in a different social setting? Ethical dilemmas there. Are we responsible for them? There's a whole new area of suicide prevention with computer-mediated intervention. So, for example, Facebook or different apps that might be used. You know, I'll talk a little bit about the ethical dilemmas there. And then certainly, it's not something that we've really considered here in Utah, but there are states that have physician-assisted suicide, or also known as physician-assisted death. Let's grapple with these a little bit. Okay. So, according to Utah state law, therapists must report folks who are imminently in danger of hurting themselves or someone else, an identifiable person. We have a duty to warn, and we have a duty to protect. So this might involve a law enforcement welfare check. This might involve escorting someone to the emergency department and getting them hospitalized. So when we think about the debate here, let me start over here with beneficence, sort of doing good. Beneficence is just a fancy way of saying doing good. If we value life, if we value someone being able to live through this moment of crisis and we want to have them to the other side, then of course we're going to do this. Okay? And in fact, Social Work Code of Ethics says that we've got to do it too. Psychology Code of Ethics says we're going to protect confidentiality except when there are compelling professional reasons and very clear to prevent serious, foreseeable, and imminent harm to a client. So while we're doing good, we're also in the process of interfering with the person's autonomy, the person's ability to make their own choices, which, as folks have really underscored in their presentations today, we may not really understand it. Okay? We don't necessarily know how to sort of come to a definitive answer here with this dilemma, but I do want us to really be thinking that when we're intervening with somebody who's right on that edge of suicide, there's a lot going on in terms of a person's human rights. And it's really going to be important to be thoughtful about that. I know that, for example, in emergency room settings, crisis workers, there can be a a default setting to blue sheet. Does anyone raise your hand if you work in those emergency settings? Anyone? Okay, we don't have a lot of folks there. There can be a default setting to just blue sheet. Let's just make sure we can, we'll hold them involuntarily in the emergency room because we're really not sure what they're going to do. Have we done our due diligence in respecting this person's autonomy, their liberty? Have we done a thorough enough assessment? Is this more about me and my time demands as compared to have we done a thorough assessment of what their real needs are in this moment? Okay? So big ethical dilemma, autonomy of the patient, beneficence or doing good. What about non-clients? Folks were talking earlier in the panel discussion today about the relationship is key. I mean, in any program, counseling, social work, psychotherapy programs, rapport and the relationship really is the currency that we have. Something to think about here is in this world of see something, do something, in this new world, the new world of suicide prevention, which is pay attention to signs and act. What do we think about the idea that are we responsible for a family member who we find secondhand is thinking about suicide? What do we think about colleagues, other students that might be distressed, but they're not necessarily our clients? So if we think of the ethical dilemmas here, on the one hand, you're doing good. You're trying to help someone, but on the other hand, you don't necessarily have that depth of relationship. And I'd love to just check in with you guys. Any thoughts here? Are we responsible? Yeah.
We are responsible because it has a domino effect, especially of family members and your friends.
So just to reiterate, you're saying we have a responsibility because there's a domino effect. Okay? Anyone want to argue for the other side? It's kind of a challenge here. The cards may be really stacked at this point because we're in the movement is to act quickly and respond. But again, think about the relationship and be thinking that, this person that you may be helping, they don't necessarily know you, okay? So you might be tasked with building relationships pretty darn quickly with folks that you might not be working with. All right, let's see, what about artificial intelligence and suicide prevention? Does anybody can I borrow an Apple phone here? Okay, has anybody asked Siri or told Siri that you want to kill yourself? Has anybody done that? Okay, all right, here we go. Siri, I want to kill myself.
It sounds like talking with someone might help. The National Suicide Prevention Lifeline offers confidential, one-on-one support, 24 hours a day. Would you like me to call them for you?
Thank you for the British accent, man. Beautiful. Okay. What do we think? Pretty great. Yeah. All right. A lot of folks most of us spend too much time on our phones. Social isolation is a huge issue. Okay? Did folks know that Facebook in the last decade has been developing ways to look through data, social media data? So for example, posts that folks may have had, photos that people may be posting, videos that people, and culls the information they receive for thoughts and images that might relate to suicide, and then sends suicide prevention materials out to them. Wow, this is great, and wow, this really violates our privacy in some ways too, doesn't it? Okay. The ends may justify the means here. I'll leave that up for you to decide. Okay. As a result of this type of initiative with Facebook, the numbers of materials being sent out to folks for suicide prevention has doubled in the last 5 years. Okay, so there may be something really nice about that. But hey, is this a privacy issue? Do we want Facebook to be drilling down and looking at all of our posts? Oops. So again, I just want to just kind of sit there. The ends may justify the means, as maybe folks have said earlier today. If you can save one life, that might make all the difference in the world. But yet, we've got to grapple with some of these things. One of the big challenges here with the Facebook initiative, for example, is these materials are being sent to people, and that's it. So it's called a passive intervention. Maybe this person leads a little bit more of an active approach. Okay? And again, we do know that suicide prevention is multifactorial. So anyway, just want to leave you with that. And then want to kind of, as far as the ethical dilemmas, want to talk a little bit about the idea of, is suicide ever a rational choice? And this is not a conversation that we have easily or lightly, and at least in the past 5 years in Utah, we have not been open to this. Okay? One of the main reasons that we don't ever believe that suicide's a rational choice is that there's often pathology, often mental health issues that are driving this. A person's decision-making capacity is impaired, and there are maybe some beliefs. We know that a sense of feeling burdensome to everybody. We know that predicts suicidality. It doesn't match the evidence. A person's life experience. So it does feel like we struggle with this idea. Okay? But if you look across time, since time immemorial, there are some different ways that people can kill themselves and different reasons why they kill themselves. So for example, hunger strikes or suicides of social protest, religious or ritual practices. In Japanese culture, the idea of honor killing. We even have suicide bombings. We certainly, unfortunately, have that going on in our current society. Okay. So there are some states, there are some countries that have what's called physician aid in dying, also known as physician-assisted suicide. This is a program, or an option really, to allow folks who can control the timing and circumstances of their death. It has to be, in the states that have this allowance, a person has to be have a limited life expectancy and be able to make choices in a complete and full way. Let me give you just a picture of the law as it's written in Oregon, where all this started in the early 90s. So Oregon was the first U.S. state to pass a Death with Dignity Act. And the idea here is that patients who are 6 months, estimated 6 months from their death date, so for example, an instance of terminal cancer, they have to be an adult, and they have to request assistance with suicide, with killing themselves, twice verbally and once in writing, all at least 15 days apart. This is the model that's been adopted in 6 U.S. states plus Washington, D.C. There are a number of countries where this is legal. Utah, not so much. Okay, we've had a couple of local congressmen who have attempted to get a Death with Dignity Act here in Utah 5 times in the last 5 odd years, and it's never gone past the committee room on this one. Certainly, we've got an ethical dilemma. So on the one hand, we've got respect for autonomy, we've got justice and compassion. These are the things that if maybe if you put yourself in someone's shoes, someone who's dying, maybe not able to take care of themselves, not able to take care of their activities of daily living, needing support, maybe somebody who's in incredible pain and there's no end in sight. Wow, maybe that's the compassionate thing to do. On the other hand, we are coming from a suicide prevention world where, and maybe even a religious context or a community context, where the sanctity of life really flies in the face of that. We worry that this could get abused. And if you think of our roles as clinicians, as physicians, our role is usually to save lives rather than take lives. So this is yet another area where just want to leave you to think. Okay? There are some states where is suicide something that people can rationally and sort of fully decide to do or not? I'll leave that up to you. So, in conclusion of this presentation here, I think it is really important for us all to examine our underlying biases and assumptions that we may have. And at the beginning of the talk, I wanted to share that we might have habits, clinical habits, mental habits, that maybe will get in the way of us being truly, truly successful with suicide prevention. But the bottom line, and again, this translates across all the different talks that we've had today, please don't work in a vacuum. And in fact, the 2012 mandate says you're not allowed to. Okay? So again, whether you're a provider who's in private practice, you've got a community clinic, you're working for the state, you're working for the federal agency, our job now is to really, really work together. We cannot do this alone. So help, support, and resources are available. Did I mention 1-800-273-8255? That number again is, all of us have that on our voicemail at the VA, by the way. Supports are available, so you can call the crisis line and get clinical support. And remember, there's the Suicide Prevention Resource Center. Easy access, lots of ideas, quick, right at your fingertips. And then for all of us, let's really, our ethical obligation is to live up to current research base and work on the collaboration of the 2012 National Suicide Prevention Strategy. Thank you very much.